And we are back on the Zero Hour. I'm your host, Richard RJ Eskow. As you know, as you probably know, as I've mentioned on this program, a new Medicare for All bill was introduced in the House of Representatives by Representative Pramila Jayapal. I expect there will be a Senate version soon. And we also have a new report from Public Citizen on, well, the way I would paraphrase it would be on the price we pay for not having Medicare for All. The co-author of that report joins us now. Eagan Kemp is a healthcare policy advocate for Public Citizen. The paper, which is publicly available, is called Unprepared for COVID-19, How the Pandemic Makes the Case for Medicare for All. I've read it. I found it of great interest. I think you will too. So first of all, Eagan Kemp, thanks for coming on the program.
Yeah, thanks so much for having me. I'm glad to be here.
Oh, absolutely. And, I could summarize the paper, I guess, but probably would be better if you did that. So tell us what your conclusions were briefly, to start and how you reached them.
Yeah. Happy to dig in. I mean, you're right. It really more tells the story of sort of a failed healthcare system and how it hurt Americans because of the COVID pandemic. The main story that we tell is really that the profit drives our healthcare system as opposed to patient need, and that corporations always win out over communities when it comes to where the dollars go. And so it meant that we have, for-profit insurance, we have, hospitals that are either, getting bought up by private equity, or rural or urban hospitals that aren't as high profit, about to go out of business. We've got drugs that are far too expensive for people. Just up and down the line of our healthcare system, whether it's nursing homes, whether it's, drug prices, we really struggle as a country to meet the needs of the American people. And that really put us at a disadvantage when it came to COVID-19.
And one of the things your paper, I think, rightly emphasizes, I don't know if report might be a better term, but one of the things that I think it rightly emphasizes is that to the extent that we have a quote unquote system at all, it's not just for-profit health insurance, but it's also for-profit pharmaceutical manufacturing. It's also for-profit hospital care and other forms of care being bought up by for-profit chains and so on. So you have this sort of concentric rings of profit taking and the dedication to profit rather than to the mission of providing medical care to people. And that really, as you say, as your report says, our healthcare system has been failing Americans for decades, and its weaknesses were particularly susceptible to the challenges posed by the COVID-19 pandemic. Your number one item on this is private insurers profiting by limiting access to care. And I think that's such a great point that people don't really think about, which is that a private for-profit health insurance company, by definition, its financial incentive is to get your premiums and not give you care. And I think that factors in significantly to your report. So tell us about that a little bit, if you would.
Yeah, no, that's right. I mean, and it's not even just sort of their incentives; it's their fiduciary responsibility to their investors. They're focused on profit, and if they're not making enough profit, their shareholders are gonna throw a fit. And so it really is, this came at a time where insurers were, increasing out-of-pocket costs, increasing premiums, narrowing their network. So people were already struggling. I mean, as I say in the report, 30 million Americans lacked insurance, but 47 million Americans had insurance but couldn't afford to use it. And so what's the point of having healthcare insurance if you can't afford the healthcare on it?
Right.
And this really, the insurers, in the numbers that they've been reporting on profits since COVID started, their profits keep going up, while what they're paying out is going down, down, which is ideal for their shareholders. But even they're realizing that looks pretty bad during a pandemic to be making record profits while Americans are suffering.
And I think you make a great point Egan, when you talk about the problems of people who supposedly have insurance and yet can't afford care. I just wrote a piece myself where I cited, as I have before, Milliman, the actuarial firm, saying the average family of four with quote unquote good employer insurance will pay more than $12,000 a year out of its own budget for medical care. That's an average figure. That's a lot of money for most families of four. And so when you say, for your report says at the start of the pandemic, approximately 87 million Americans were uninsured or underinsured. I don't know what you think about that. I mean, clearly it's correct, but if anything, it's overly generous to our broken healthcare system because a lot of people who aren't considered underinsured. I always think of that teacher in Texas who felt she couldn't afford the $120 for antibiotic for her flu and died. She had to make a choice in the moment. And I would argue that, I don't know what you think. I'm certainly not criticizing your report, but I would argue that if anything, more than 87 million people, virtually everyone are uninsured.
I think that's really fair. And I think that's a crucial point because you really don't know you're underinsured until it's tested. So there's so many Americans that think they've got great insurance until they really get that diagnosis that's going to bankrupt them. And I think one of the most powerful things about the launch of the Medicare for All legislation yesterday was almost every member of Congress that spoke highlighted a time that they or a family member faced either couldn't get health care or even had insurance, but faced huge healthcare costs that they couldn't even navigate. And so it really is a system that's designed to make sure that executives get their cut, that sort of all the middlemen in the healthcare system get their cut. And it's just not something that comparably wealthy countries in the rest of the world experience. People, when you describe the US healthcare system and how much it costs to get care to people who live in Canada or the UK or France or Italy, they're shocked because they can't understand why Americans would continue to let this go on. And it's because we just don't know better. I mean, I was radicalized on healthcare when I lived in Canada for 2 years and was confused at how easy it was. We at one point we kept asking who we needed to pay the bill to. Right. And they just kept telling us no one. And we just didn't believe that was the case. We just thought we were getting the wrong information. And eventually they stopped us and said, you must be Americans. This happens when Americans get care here. They get confused that it's too easy. And it really was. And it shouldn't be that hard in the US of A, where we spend the most on healthcare, but get the worst care out of it.
And that happened to me when I was in London as a student. And had to get allergy shots once a week, and it was like, well, go to the pharmacy, pick up your needles, and we'll have the medicine. And you just come in, and well, who do I pay for all this? Well, what forms do I have to fill out? I'm not British. It doesn't matter. It's a bizarrely disorienting experience, isn't it? I also,
going back to your question about sort of, what else insurers do. I mean, we're seeing new scams that insurers are running. One of them is a retrospective denial. So care that was approved, someone goes and gets it, and then it's denied on the back end. All of a sudden, that patient is responsible for the cost, which could be a lot of money, even though before they had been told that they could get it. And so they're always coming up with new schemes to make sure that they're not on the hook. And it's like, what are we paying them for? I mean, are we paying them just to push papers around? It's like under a Medicare for All system, the money that folks would be paying in taxes, and this also goes to your point of just how much people are paying right now, the average family would pay less. Nearly everyone would be paying less under Medicare for All and any new progressive taxes. The only people that would be paying more are the wealthy corporations and the wealthiest in America, who right now aren't paying their fair share and are getting away with murder.
And I also wanted to add that the other barrier that they throw up, since you mentioned cheating, right, in a sense, and certainly these retrospective denials are cheating, the other barrier that they throw up, I experienced myself about 3 years ago. I had what would be considered minor surgery. And I know the game, right? So, but as a test, I went to the Cigna website. Cigna was my insurer. And what they said was, first they said, ask your doctor, ask your surgeon if there's a cheaper alternative, which is just what you want to hear when you need surgery, right? And then the second one was to find out how much it costs, ask your doctor. Ask your doctor, quote, how much will this cost? So, of course, I asked the arrogant surgeon. So many surgeons are arrogant, with the perfect hair and everything. I asked him, how much is this going to cost? I know I'm playing a game. He says, ask my billing department. I ask his billing department. They say, ask your insurance company. I say, my insurance company sent me to you. They said, well, ask your doctor. So, this is part of the game too, isn't it? And by the way, the bill was almost $4,000, which is a lot more. I'm fortunate I was able to put it together. A lot of people can't do that. So between the out-of-pocket cost and just the runaround, they're really carrying out, as you say, their fiduciary duty to make sure you don't get the care you need. Fair?
That is entirely fair. And it's a really good point, that $4,000 is a huge expense. I mean, I was recently looking at a study that 40% of Americans can't afford a $500 unexpected expense. And so you can just imagine during COVID where people were losing jobs left and right and fearing for the need for healthcare. And just in an average year, Americans struggle to get the healthcare that they need. And it's just so complex that it's, in other countries, you go in, you talk to your doctor, you get what you need. In the US, you have to call every single person, figure out the price. It shouldn't be up to the consumer to price shop for healthcare. I mean, we hear that from the far right, that if the consumers, had more skin in the game, and it's like, if you're getting surgery or you have a health issue, you have skin in the game.
Literally, yes, you literally have skin in the game.
All you should be focused on is getting healthy, as opposed to trying to nickel and dime and get between your insurer and your provider. It's absurd, and no other comparably wealthy country has anything similar. And it's why we pay so much, because each one of those steps allows them to take a little bit out of consumers' pockets. And in the end, we end up with a system that spends so much while having so much unmet need.
And Eagan, and again, we're talking with Eagan Kemp, a healthcare policy advocate for Public Citizen. I'll go you one further in that I looked at those surveys too, and I looked at the average deductible for a private sector health plan. Surveys, 70% of Americans say they don't have $1,000 for an emergency. The average deductible is more than $1,000. Therefore, by definition, you have an insurance system that will fail most people. And so I think your report is both timely and important. And I'm sure we could spend all day hammering the private sector health insurance system. I wouldn't scratch the surface of their.
Right. I mean, the only thing I'll add on what you just said is that, it was so absurd. Some of the stories that were coming around the beginning of the pandemic last year was Americans struggling because it was too close to their deductible year beginning. That if the pandemic had hit closer in maybe December or November, people would have already paid through their deductible and then been able to get the care that they need. But because it was coming at the beginning of the year, their deductibles had just turned over and they were losing their jobs. There's no reason that a pandemic starting at a particular point of the year should mean people are more likely to get care. It just shows one more absurdity of this system that we just
couldn't agree more, mainly because I wrote that piece for the American Prospect last February on how.
Okay, yeah, that's probably it.
I remember I date back to the days when everybody was saying this was the way to provide optimum care. But even then, it was understood that some needed care would be cut off as a result of that. So yes, it's a preposterous system, which leads us to the next level of absurdity in your report, if I may put it that way, which is employer-sponsored insurance failed at the worst possible time. Again, sort of a historical anomaly, right? That unlike other countries, we had wage and price freezes in the 40s. So one of the few inducements employers could offer was health insurance. Kaiser began it. And now we have this employer-driven system, which means the person funding the majority of your insurance also has an incentive to keep prices down because it's an employer, and B, when a bunch of people, tens of millions of people lose their jobs, as for example, in a pandemic, they lose their health insurance at the worst possible time, right?
Yeah, I mean, that's the thing. This pandemic hit us everywhere we had weaknesses. And in the US healthcare system, it's a lot of weaknesses. 22 million Americans lost their jobs just in the fall, about 15 million of which were getting their healthcare through their jobs. And so all of a sudden, in the middle of a global pandemic, you have 15 more million Americans who aren't able to get access to healthcare. Their options are exchanges, who, with the Trump administration, refused to do an open enrollment period, or COBRA. And who can afford COBRA? I mean, if you just lost your job, that is the worst time to even consider paying for COBRA. And to go back to the business point, I mean, one of the most fastest growing areas of the Medicare for All movement is businesses. Businesses are realizing just how absurd this system is for them and just how little they can handle being competitive. I mean, Debbie Dingell consistently talks about how U.S. car manufacturers are at a disadvantage compared to international car manufacturers because of the healthcare costs that those companies have to bear. And, you know, everywhere from sort of the biggest companies to your smallest mom and pop shops struggle because they want their people to have healthcare, because that's how you have a healthy workforce, but they can't afford to provide it, or they might go out of business if they do.
Right. And, you know, I'm so glad that that's becoming more widely understood in the business community. I do remember many years ago at a conference, a CEO said, "Oh, you know, you lefties, the lefties want to drive the car when it comes to health insurance." And then he took out his car keys and said, dangled them and said, "Well, I'm sick of it." Dropped them on the ground. He said, "Take it. I can't afford this anyway." Right. And I think that's, you know, he was right. I'm glad people are catching up with him. And of course, for employee, you know, we've got the American Rescue Plan now, which continues, you know, pays for COVID, but they'll still have the out-of-pocket costs. That only helps people who had a job that they lost. So, you know, it's not universal. And I want to, Eagan, Kemp, I want to get to another point you raised in your report, and you and your co-author, which is for-profit hospitals. Your next section of it addresses the fact, it says hospitals focused on profit and revenue were unable to respond to COVID-19 while safety net hospitals faced closure. So this, again, I mean, tell us a little bit about that.
Yeah, I mean, we really are at a time where you're either a hospital that's profitable, and you got profitable by buying, building a fancy new cardiac wing. There was a recent study that found that the most likely cause of a hospital building a cardiac wing is the nearest hospital just built a cardiac wing. So it's not about community need, it's about remaining competitive and profitable. And so they have, you know, corporate investors, for-profit investors, private equity, Wall Street, that are putting money into them to buy these sorts of things, and then they're directing their patients to them. So all of a sudden, they're providing unnecessary or over-providing care. I mean, we know that in the U.S., 1/3 of care that's provided is unnecessary or over-care. And so in addition to sort of the waste throughout our healthcare system, people aren't getting the care they need, but at the same time, some people are getting too much care. And that's also, you know, part of the profit motive. And then at the same time, on the flip side, we have rural hospitals, urban hospitals, safety net hospitals that are going out of business because, you know, they're dependent on elective procedures. They don't have a consistent source of funding. Under Medicare for All, you would have global budgets that would be tied to community needs. So, you know, the things that would be where hospitals are would be determined by, you know, what community they would be serving. We would no longer have, you know, places in Montana and Utah and in rural southern counties that are without hospitals. I think it's something like a majority of Tennessee hospitals are now, counties are now without a hospital. And that means people are traveling 2 to 3 hours for care. If you have a cardiac event, 2 to 3 hours, you're not going to make it. And if you do make it, you probably were there by an air ambulance. Now you're on the hook for a $40,000 bill. So you might have survived, but can you survive that bill? And it's just all the wrong incentives in all the wrong places.
Absolutely. And you know, I think the only political problem we have in talking about this sometimes is that people's brains melt as they start to understand how insane it is. And I remember, I'm going to have to look for this. I remember back in the 80s, there was a paper on the medical economics in San Antonio. There was a new high cost technology. I can't remember if it was like CAT scans or something that's normal now, but there were two hospitals in San Antonio. One of them bought one of these units and it was used 65% of the time. The second one bought one of the units. It was used 65% of the time, which makes no sense if it's driven by need. It only makes sense if it's driven by exactly the financial incentives you're describing.
Well, and that's I think the scary thing that we're seeing is it's not just for-profit hospitals anymore. It's not-for-profit hospitals as well that they're also experiencing the same pressures. I mean, they call it revenue, but it's still, they're taking the same steps that a for-profit hospital would take and facing the same incentives. And it really, it confounds care. So we have, some of the most beautiful hospitals in the world, but they're not meeting their community need. And for-profit hospitals right now, there's a lot of concern that they're not even meeting sort of the charitable standard that they're supposed to be meeting to remain nonprofit. And so it's a huge controversy even within the industry of whether those hospitals should even be considered nonprofit at this point.
Yeah, no, I think I remember the president of one Catholic hospital chain saying, we have a saying here at the Daughters of Charity or whatever, no margin, no mission. And the margin can take over the mission. And I think we've seen that happen a lot. Your report, by the way, and again, Eagan Kemp's report can be found at Public Citizen, raises a very important point that I think gets lost in a lot of discussion of Medicare for All, which is that Medicare for All, as it's been proposed, includes global budgets for hospitals. You bring up global budgets. I think it's so important because I hear a lot of people say to me, well, I like the principle of single payer or Medicare for all, but how are our hospitals going to get by on Medicare rates and then they'll all close and we can't go to the hospital? Maybe you want to explain that briefly because it's exactly the opposite, right?
Yeah, I mean, and that's what we're seeing. If you're worried about hospitals closing, you should be worried about our current system. Right. The COVID-19 crisis exacerbated an already huge crisis in hospital closures across the country, really. I mean, in rural and urban areas. GAO, the U.S. Government Accountability Office, where I worked before Public Citizen, just had a report highlighting just how much one hospital closure in a community can hurt people and increase their times that it takes for them to get care. And so under global budgets, you would finally have consistent funding year to year for every hospital. And it would mean that their funding would grow proportionate to their needs. So if a community is growing, they would be able to sort of, take on additional funding each year. And in the bill, there's emergency funding for things like pandemics, natural disasters. So all of a sudden, these hospitals, when they get hit the hardest, would have an influx of money, whereas right now, they really struggle to meet the needs of their community in an average time. But when it comes to a pandemic, especially if they're getting overwhelmed, have too many COVID cases, really just can't handle it and further likelihood of going out of business.
Yeah, absolutely. And you have... I know you have a time limit, so we won't be able perhaps to explore these in as much depth, but certainly nursing homes were overwhelmed and understaffed, and you talked about that with catastrophic results in many parts of the country. If I recall, the last year's, anyway, Medicare for All proposal included coverage for long-term care, didn't it? Because I think that would move... If these nursing homes were not for profit and if there were a dependable source of funding for them, I mean, I think it's ghastly now. I took care of my mother who was in a nursing home, my aunt who was briefly in a nursing home at various points. It's just, to me, it's a Dickensian system, really. But
it's another sort of historical anachronism of our healthcare system, that it's sort of, Medicaid was never intended to be the primary payer of long-term care, but it's turned into that because we never created a long-term care system. There's been attempts to do long-term care insurance, but it's always far too expensive. I mean, there's consistent stories about people that thought they had good enough long-term care insurance and blew through it in 2 years when they or their spouse ended up with dementia or some other, particular challenging long-term care issue. And so right now, people, and a lot of Americans, I think that Medicare will cover their long-term care, but Medicare doesn't cover long-term care other than for stays directly after surgery, and it's a short period. So folks end up having to go on Medicaid, which means they have to spend down their assets until they're in the poverty level, and then they can get Medicaid, which only pays certain rates. It's obviously one of the better things because it's one of the only things available, and states can supplement it with access to home and community-based services. But it's still not a system. It's a hodgepodge of various systems. And I talk with disability and aging rights folks that talk about it took them a decade to cobble together from 8 to 10 programs that enough care to just live a normal life that if we had Medicare for all, they could make one call, have a couple meetings with the relevant people, and get the care that they need. And it's just something that another part of the healthcare system that's just been so complex and so challenging that people don't expect that it can get better, but it will get better under Medicare for all.
And the homes themselves, I think,
definitely. The incentives are all wrong there. That it's really about packing as many people in as you can and then hiring as little staff as you can, which obviously is the perfect situation to spread a disease. And even before COVID-19, folks were reporting on the spread of contagious diseases within nursing homes and the need for HHS and states to step up to improve it. And then COVID-19, just ran rampant through them. And part of that is bigger picture stuff, not just Medicare for all, but Fight for 15. Home health workers, nursing home workers get paid so little, they need to work 2 to 3 jobs. And so if you're working at 2 to 3 nursing homes, and just one of those patients has COVID-19, then you're taking COVID-19 to those other 2 or 3 nursing homes and infecting all sorts of other folks. But if you got paid a decent wage, could work at that one nursing home, all of a sudden the spread's a lot different. And that's why our system was just perfectly set up to fail in so many ways.
Yeah, tragic. And your report makes the case beautifully for Medicare for all as a substitute system for all of this. Now, Eagan Kemp, I know that you have a hard deadline, so and your report also addresses how this made existing health disparities worse, which perhaps we'll talk about at another time. Any closing thoughts before I let you go?
I appreciate you having me on. I mean, I really hope the American people will take a close look at Medicare for all. I mean, it's a growing movement. There's a lot of work to be done at even the state and local level in terms of passing resolutions, putting pressure on members of Congress that aren't there yet. We did have a record number of original co-sponsors this year, so we're so excited about that. We know we're going to have hearings in both the House and the Senate. So I hope people follow along and get in contact and join the movement.
Wonderful. Well, the report can be found at citizen.org. And it's called, let me get the title again, sorry, Unprepared for COVID. I was unprepared. Unprepared for COVID-19, How the Pandemic Makes a Case for Medicare for All. So Eagan Kemp, thanks for your wonderful work on this report, and thanks for coming on the program.
Yeah, thanks so much. Really appreciate it.
It was a pleasure. And we'll be right back after this. I am RJ Eskow, and this is The Zero Hour.